Okay, well, I see the rapidity of entries is still happening, but slowing down a little bit. So I think I'll get started with greetings to everyone and welcome to our Thursday morning HIV Center Grand Rounds. It's good to see you all here. Hope people are doing well and coping through this rather cold winter and our ongoing challenges with Omicron, et cetera. Hope you're staying well and healthy and staying warm. As always, I'll let you know about some of our upcoming grand rounds. On February 17th, we have Monica Gandhi, who we all know is a leader in research, and she'll be talking about HIV adherence metrics and keeping us up to date on that. So that's on the 17th. On March 3rd, we have one of our double billing of our early stage investigator grand rounds. And we have two presenters. We have Christina Ivedian, and we have Anthony Santoro from our own fellowship program. March 24th, we'll have a very interesting grand rounds, a little bit different from some of what you're used to, but I think very important in this day and age. Scott Latendry will be talking about complex cognition and the influence of HIV, excuse me, and comorbid diseases on brain biotypes. And very importantly, I want everyone to mark their calendars for March 31st. So March 31st, we're going to have a special grand rounds, and it will be a Zena Stain commemorative rounds with several speakers at that round. It will be the first kickoff of Zena Stain, who you all know we lost just a few months ago. And, a founding director of our center, important global leader in the field. So March 31st, please mark your calendars for that very special Zena Stain commemorative rounds. I think Teo, you at least have an announcement, maybe a couple more announcements before I introduce our speakers.
Yeah, thank you, Bob. I would like to introduce a new fellow who started in our program a few days ago and who will be working with Bob Remien. And his name is Paul D'Afonso. And Stephen, maybe you can give him permission to show his face so we know what he looks like. And Paul, maybe you can say a little bit about yourself.
Did you give him a heads up? Does he want to show his face?
I did.
If you can hear me, we'll just do audio if that's fine.
Okay.
Hi, good morning, everyone. Thank you. Yes, as Teo mentioned, I'm joining as a new fellow. I completed my Ph.D. last May in social behavioral health sciences at Temple University. Since then, I've been working with the Center for Health, Identity, Behavior, and Prevention Studies across the river at Rutgers. But I'm very excited to be joining you all as a fellow and to be attending my first HIV Center Grand Round. So thank you.
Welcome.
Great.
Thanks.
Welcome. Any other announcements? Anyone would like to make an announcement about some special event or piece of news that would be of interest to this audience? If not, I will move on to today's session. And as you know, this is one of in a series of having our former postdoctoral research fellows come and speak with us. And so today we have two graduates of our fellowship program here at Columbia and in the HIV Center, led by Teo Sanford. We're really very proud of all of our fellows, and we take great pride and joy in having them present to us in our ongoing Grand Round series. So thank you, Teo, for developing this ongoing series. I think it's been really wonderful. I will introduce each speaker one by one before their time to present. So first up is Dr. Miguel Muñoz-Laboy. He is an associate professor at the School of Social Welfare at Stony Brook University in Stony Brook, New York. Dr. Laboy received his doctoral degree from the Department of Socio-Medical Sciences here at Columbia University. And as I said, did his postdoctoral research training with our HIV Center in psychiatry here. Most of Miguel's work is focused on examining the socio-cultural and structural determinants of health risks among youth and adult males in communities in Buenos Aires, Durban, South Africa, here in Hartford, Connecticut, Hanoi, Vietnam, New York, Rio de Janeiro, San Juan, Puerto Rico. So you can see he does a lot of global work. More specifically, his research examines the influence of masculinity, culture, religion, and sexuality on risk behaviors and health outcomes. So we're very pleased to have you here today, Miguel. I'm going to turn it over to you, who will be talking to us about addressing chronic loneliness as a determinant of behavioral health for migrant youth and emerging adults. I turn the floor over to you. And as usual, just a reminder to everyone, of course, be on mute during the presentations. We will have discussion and Q&A after each of the speakers. And as usual, my colleague, Stephen Sukumaran, will facilitate that discussion. Okay, you take it away, Miguel.
All right. Let me start sharing the PowerPoint. I'm going to start my timer. Good. It is a great pleasure to be here today. And I was a postdoc fellow from 2001 to 2003. But before that, I was a fellow of some sort in a minority supplement with Dr. Alex Caraballo. So I feel like I'm a child, a son of the HIV Center and the Department of Social Medical Sciences. So today's presentation, it's about my journey to understand loneliness as a social determinant of health. And to examine it and to see whether, is this a real determinant, or is it, so we can debate about that in the discussion. But the journey with loneliness really starts my work in the HIV Center with Dr. Jennifer Hirsch. We were doing, this is after my postdoc when I'm in the Department of Social Medical Sciences, and we're doing a project on the social context and organization of sexual risk among Mexican migrant workers. And in that project, we did, it was a cross-sectional study, mostly qualitative, but we included an instrument. We did a survey with 50 individuals, and in the instrument, we had the idea that there's issues of social isolation, but there might be issues of loneliness. And we decided to include the UCLA loneliness scale. Now, loneliness is we all have experienced being lonely. It's a very natural experience. The problem is when loneliness is chronic and it takes and it doesn't go away. Yeah, so it's a perceived notion of social isolation. And these are some of the items in the UCLA loneliness scale. And Stefan has shared with you the PowerPoint, so I'm going to go a little bit fast, but the material is there, so you can read it calmly. And in that study that I did with Jennifer, we found that a lot of the migrant workers have very low social connectedness, have difficult quality social relations in the context of the US, and had high levels of loneliness. And loneliness was inversely associated with age, meaning the people who were younger were scoring higher in the loneliness scale. And then loneliness was a determinant of sexual risk behavior, particularly with condom-less sex and condom-less vaginal sex with alcohol. So I took the scale and I use it from that point forward in a lot of my studies. And this, again, just to revisit, this is a 20-item scale. It ranges in the scoring from never to often. The reliability of the scale was around 0.94. The alpha, Cronbach alpha was 0.94 to 0.95 in most of my studies. And scoring 45 or higher is considered chronic loneliness. But this is by the people who have studied loneliness for way longer than I have. And in my subsequent studies, around 37 to 48% of the samples had experienced chronic loneliness. So I'm gonna go over them briefly. And so this is a study I did in R01 from 2009 to 2014. And in that study, we focused on Latino bisexual men. And we found that to some extent, they did have high level of social connectedness, but there were some parameters in the quality of the social relationships that make that social connectedness not so effective, particularly with regards to family conflict and issues related to sexual identity, meaning conflict because they were bisexual and they were openly bisexual. Again, loneliness was also a determinant of risk. And it was associated with condomless sex, was associated with alcohol, drugs, and now in this study I included depression and anxiety, and it was also associated with that. Now, of course, there is reverse causation that can happen, and remember, this was a cross-sectional study. From 2009 to 2013, I have an RC1 grant, and I did the same thing, focus on formerly incarcerated Latino men who have been released from prison within the past 3 years. And pretty much a little bit of the similar elements of high social connectedness, to some extent, dense networks, but the quality of those networks were problematic in the sense that there was very little social support. There was a lot of strain in family and marital conflict. And again, loneliness was associated with sexual risk behaviors, but also with substance use and with depression and anxiety. But again, that was another cross-sectional study. From 2013 to 2019, at this point, I'm at Temple University, and we have this demonstration project, which is kind of, it's like a trial. It wasn't a randomized trial for people who were substance users who had severe opioid use disorder. They were actively injecting or using heroin at baseline. They were HIV positive, but they were also out of care by the definition of the CDC. And at baseline, we have, again, poor social connectedness, very little networks that they can draw on. The quality of the social relationships was very depleted. And in this sample, age was not associated with loneliness. However, it was associated with polysubstance use, depression, anxiety. It's kind of a similar thing. Now, 12 months later, and after the intervention, in a way, we were able to create or produce a little bit more of social integration and moderate social contact frequency, but the other parameters in social connectedness we were not successful in that. We were able to increase the level of social support and build with the participants how to build social support networks to support them in their HIV care, as well as in the substance use care. However, loneliness remained a problem. And the intervention wasn't about loneliness. The intervention was about HIV continuity of care. So loneliness did remain a problem and remain a determinant of substance use and anxiety and depression. Now, there are a lot of limitations on my research on loneliness, meaning a lot of these samples are people who are marginalized, who are economically marginalized, socially stigmatized. So there are a lot of moments in the notion that they might feel lonely. Yet that doesn't justify that we don't need to intervene. A big moment happened in 2020 when I started working with Dr. Melissa Bezaja, who works specifically on social isolation and loneliness with migrant youth and emerging adults. So we combined forces, and I learned a couple of things. In 2018, Generation Z, that means adults ages 18 to 22, has the highest loneliness score in the country. This is, again, prior to COVID. Prior to COVID, our younger adults were experiencing a tremendous amount of loneliness. So what I did was I began to understand a little bit of the kind of the social elements of the psychosocial functioning of addressing loneliness, not simply as a raw determinant of risk, but also as an element, as a key in the pathway to healthy adulthood. And loneliness is a threat to that. So we joined forces and started to do projects and started to write R21s, R01s, and we were not successful in the first round, which is fine. And we got a seed grant. And this is what I'm going to present briefly today, some of the highlights of that seed grant. And the seed grant was to work on preventing social isolation and loneliness from the perspective of legal, educational, and social services providers. And the project, again, the goal is to develop the content of a comprehensive multi-level loneliness reduction intervention. And the seed grant allow us to get that data so that then we can feed it into the R21s and R01 preparation that we're doing. And it's like kind of the aims that I already mentioned. The methods are, in a way, simple. It's 2 methods: focus groups first, and we did that this summer, and we finished it around September. And focus group with providers. These are mental health, legal, social, educators, or primary care providers. We recruited them through a whole set of networks in New York and Long Island metro area. They have had to work with migrant youth or emerging adults. And we did it through Zoom. We did 6 focus groups and 28 participants. These are some of the questions that we asked them, all the way from, do they perceive that loneliness is a problem? Can you tell us about the strengths of your community? What is it that you're doing that might help us in addressing this? And then the data analysis, we did constant comparative analysis, open coding. We have 4 reviewers and 3 rounds of reviewing the data. And then we depict the common themes. Method 2, I will explain later, is the community collaborative board, which is what we're doing right now. And let me just give you some of the highlights of the findings. Social isolation and loneliness from the provider's perspective. They argue that the experience of migration itself created social isolation for this group. Again, these are issues that precede COVID. And they define migrant youth and emerging adults at 3 or 4 groups. Those who travel with their parents, those who drop out of a school but resides with their parents, those who are unaccompanied minors, and those who are out of school age. Here's just a brief quote. In this quote, the school counselor tells us, a student from South Asia country, she transferred from another school. She really did suffer isolation. She said she was lonely. A lot of bullying from her past, and just appeared to be a very emotionally broken person because of her experience of being called all sorts of names like terrorists and things of that nature. And when she transferred to our school, it was really difficult for her to trust us. Loneliness among Maya was also perceived among participants to be the result of the tear down, of the constant isolation and constant migration-related issues confronted by migrant youth. This is a migration lawyer who also had an MSW. And some of these issues include English language barriers, economic hardship, discrimination, work permit issues, or legal status issues. But the most prominent issue that they identified, that there was consensus, is that migrant youth do not have the opportunity of being youth, do not have the opportunity of experiencing what other youth can experience, because they have to assume parenting roles often as part of their taking care of their siblings or working as part of survival. And we asked them what services are available in their communities, and there were a lot of services available. And they agree that there were a lot of services that were available, but available does not mean engagement. So there was a breakdown into the services that might be available to support and create social connections for migrant youth, but youth are not engaging. And then we talk about barriers, and this is a list of barriers that we did a lot of consensus building, and these are the top 8 barriers that they identify that people just don't have, migrant youth or their families don't have access to them. Another type of barriers were initial quality barriers. That means that the first encounter that a parent or a migrant youth might have with an agency, there might be some limitations from the start, all the way from having service providers that don't speak the language, to providers relying on online searches or almost randomly finding people without knowing the quality of the services, staff burned out, meaning that they were treating participants not so nicely because they were burnt out, and there was just limited staff with cultural competency. Now, even when the services are available, accessible, and the initial quality was good, retention in services is an issue. And when I say services, I'm referring all the way from youth social support groups to cultural events, type of things that promote social connectedness and can address some of the issues of isolation. And again, it goes back to competing needs for younger siblings or trying to take care of younger siblings. But also there was a speculation of distrust in agencies and not being able to really identify people who are experiencing loneliness, that there was a lot of issues of training staff and training educators and training all people who have first contact with migrant youth in how to address their social and emotional learning needs. But there were some successful stories, and this is, I just check time. There were some successful stories, and in this one, one of the focus group providers tell us about this young individual, and I quote, the first group we had this young Middle Eastern country female who was around 12, I think, today she's 22. She went through a lot of issues in terms of depression, anxiety, in terms of isolation, and not being accepted by her family as she came out to be bisexual. She did connect with some other Middle Eastern Muslims who were coming out as bisexual, lesbian, or just within the LGBTQ community. I was able to connect with her in those resources. Today, 10 years later, she actually runs one of the youth empowerment programs. So this type of experiences help us to try to figure out what is it that we need to reproduce? What is it that we need to develop that can potentially address issues of loneliness and isolation? This brings me to the second method, which I'm just gonna mention. I'm not gonna mention results because we don't have any yet. We're in the middle of it. In this method, we draw in Rogerio Pinto's approach to community collaborative board, and in Dr. Marita Merman's, some of you may know her, intervention mapping methodologies, or that's the person I learned from. And the idea is to do we have built this community collaborative board. We have 12 representatives, again, from lawyers to social workers to educators. We have an incredible attendance, which is the mode it's like 100%. Most people come and it's this volunteer, and we meet once a month or twice a month, and we really talk about interventions and tools, and we're very rigid in following the intervention mapping methodology. So some of the semi-conclusions I have, or it's like, there are two areas. One, we need the development of social environmental interventions on increasing social connections. We also need interventions that allow providers and educators to detect chronic loneliness at the organizational level. Yeah, these interventions are at the organizational level. And for that, we have our community collaborative board. That's what we're developing. We call it the Preventing Loneliness and Social Isolation Working Group. And we're planning to use together, resubmit this R21 for developing kind of an organizational level intervention. The second gap that comes out of the focus groups, and it's still very clear, is that the data is kind of not great in terms of the causal pathways that are, and the mediators that are amenable to change between loneliness, social connectedness, and behavioral health for migrant youth. And we are working again to resubmit this R01 that was scored at the 36th percentile. So now we know that nowadays that's definitely not fundable, but with this data, we hope that we will get funded. Also, one last thing, parallel to loneliness, I'm also working with another postdoc fellow, Dr. Juan Martinez. We have been working now for years. So this is our second NIH grant. It is an R34. And what I'm trying to do is for you to invite us to present in 2024. I want Omar and I to present the results from this R34, because I think it's a fantastic way of thinking about structural interventions for HIV continuity of care. So with that, I thank you.
Thanks so much, Miguel. A reminder to our attendees, if you have a question for Miguel, you could enter it in the chat or the Q&A feature, and I'll read it out on your behalf, or raise your hand and I'll unmute you. First, Miguel, we have a question submitted anonymously. They ask, were smartphones and or social media use assessed as competing activities that may have reduced retention or engagement in programs and contributed to feelings of loneliness and isolation?
Well, we haven't worked with the youth yet. So we work with the providers, and the providers did agree that in a way, there are a lot of elements of social media that contributes to loneliness. But we did not assess that with the youth yet. This is something we will do in the R1.
Any other questions?
Miguel, it's Theo. It's fascinating to see how your theme was there a long time ago and how it has evolved, and that you're still collecting data and in a way expanding your thinking about it. If you would step back from the data and share with us what how your thinking has evolved. So not so much, so not based by what you actually found in the studies, but what you are thinking about loneliness and how you conceive that now. Because I assume that in those 10 years, or in the, well, 20 years, wow, in those 20 years, your thinking must have been developed, because you know a lot more now than you did 20 years ago.
Mm-hmm. Very good. Thank you.
I know it's a broad and open question, but I assume that you're able to answer it, or to give us some ideas.
Well, thank you. I think that to me, what I have learned a lot of the psychosocial elements of loneliness and the dimensions of loneliness that I didn't have before. For example, I used to work with mostly men and men, especially a great quote was, you know, we talk and say nothing. So, so again, the intersection of masculinity and loneliness, and I was focusing more on loneliness has it related to masculinity, and I think it has shifted. Now, when I see loneliness in terms of the data, and then when I pair with Dr. Besaja, it's like, wow, this is a really strong determinant of behavioral health. It has an impact. And this is all again before COVID, and then now COVID came. So it's like, so I raise my hands because a lot of us don't know what to do. We're trying, and then of course the past. This has been very hard for migrant families. This before COVID, the prior administration made things really, really hard, and the distrust, it's incredible, and the damage that was done against the migrant community. So, and I think I have expanded my notion of loneliness from related to masculinity again to more, and I'm not a psychologist, so I have to pair with psychologists, and that's okay. I love it, so it's great.
Thank you.
Miguel, another question. What, from your perspective, would be the best ways of intervening to reduce loneliness in migrant populations and youth? I am wondering about individual versus group or community interventions.
I think you need interestingly enough, that we're talking about the 3 levels of interventions. You have to create an environment where people have connectedness. We have to work with individuals to give them some language, because sometimes if for example, if that kid that I showed the quote had not said that she was lonely, it would be very hard for the provider to intervene. out of the blue. So the notion of giving kids some language to talk about feeling lonely, feeling depressed, it's another great marker. And the mental health stigma, addressing some of the mental health stigma that exists in a lot of migrant communities. So I think that it has to be a multi-level intervention. It cannot be individuals alone. It's like I want friends, but I cannot force other people to become friends of mine. So we need to create opportunities for them to have social connectivity.
Thanks, Miguel. And we have a comment in the chat that maybe you can reflect on. Laura Adams says parasocial relationships or social media relationships can act as a placebo for feeling less alone. It can distract the individual from their actual situation, delaying action.
No, it's a very, very good point. Very good point. And probably one of the things that we will assess when we do our R01, which hopefully we'll get it and do it. Yeah, and assess it. Thank you. Thank you for that comment, Laura.
Any final questions for Miguel? Otherwise, thank you, Miguel. Bob, I'll turn it back to you.
A pleasure.
Okay, thank you. Thank you so much, Miguel. That was really great, as expected. Not surprised. So yeah, now I have the pleasure of introducing our second presenter for today. And next up is Dr. Michael J. Stirratt. And I do need to personalize my introduction just a bit. Since I first met and got to work with Mike when he was project director for the SUM study, seropositive urban men study, on which I was a co-investigator back in the late 1990s. And then he became project director and co-investigator for my Smart Couples Intervention study here at our HIV Center at Columbia in New York State Psychiatric Institute. And that was in 2000. I also had the pleasure of serving on Mike's dissertation committee at the Graduate School and University Centers, so the University of New York, in his sub-program in social personality psychology. And that's where he received his Ph.D. in 2003. And I was fortunate to have gotten to be his primary scientific mentor when he was in our postdoctoral training program. It's been a really rewarding experience to witness and be part of his professional growth and development. So as you can imagine, it's with great pleasure that I get to introduce him here today. Dr. Stirratt is now a senior behavioral scientist and chief of the Adherence to Treatment and Prevention Program at the NIMH Division of AIDS Research, where he leads a large portfolio of federally funded research grants on adherence to HIV treatment and prevention regimens. Dr. Stirratt has worked in HIV behavioral research for over 20 years. At NIMH, Mike has led research initiatives to improve monitoring and support for antiretroviral medication adherence among people with HIV, as well as initiatives to strengthen delivery and use of HIV pre-exposure prophylaxis, PrEP. Mike participates in scientific working groups or protocols in multiple NIH HIV research networks, including the ACTG, the HBTN, and the HVTN. And he co-chairs the NIH Adherence Network, which is a scientific interest group providing leadership and vision for adherence research at NIH. You know, I think it's always true that the best mentees in training programs are also mentors during that process. To me, Mike is a great example of how the mentee becomes the mentor. This was true when he was in the training program with us, and has become even more true as he has advanced in his career. And I think for all of you, you'll see this, where I think his topic of his talk is long-acting regimens for HIV prevention and treatment, a social behavioral research agenda. And I see this as Mike coming here to mentor us in how we can move forward in our innovative research. So with great pleasure, I turn it over to you, Mike.
Oh, thank you so much, Bob, for the very, very, very kind introduction. It's a pleasure to be back with the HIV Center family, and I am so grateful for all of my experiences in the HIV Center. First, working on projects with you, and then as a postdoctoral fellow. That was from, wow, 2003 to 2006. So that was actually just after Miguel was there. And I really do, I've said it many times, you know, the kinds of experiences that I had with Bob and with Teo and with the wider HIV Center, it is a community. You know, through the fellowship program and through my time there, it was just fundamental to you know, my onward, you know, work and career. And you know, I could not be doing what I'm doing today in a program role at NIMH without the foundations, you know, that were set for me through my participation in the HIV Center. So I'm so personally grateful for that, and then also for the continued connections to the HIV Center family over the years in a whole variety of different capacities. Miguel ended his talk by mentioning an R34 that he has on a very innovative approach, medical legal partnerships. And that's work he's doing with Omar Martinez. And that grant is in my portfolio. So it's just, I'm always struck by the circles that we travel in, and how we all, you know, get to, you know, continue to work together as time goes by to advance the science and to make a difference. So very grateful for that. Yeah, so let me start this. So, you know, grateful for my time there. Let's see. There we go. Okay. And, you know, for, you know, thinking about this talk today, you know, I think, you know, we can all, you know, safely say that we're all very grateful for the advances that we've had in HIV around highly effective antiretroviral therapy. And I, you know, start this, you know, presentation by, you know, using this classic slide, you know, where we see the change over time that was introduced in rates of mortality due to HIV and AIDS that resulted from the introduction of highly effective combination oral antiretroviral therapy. Just to remind us that, you know, there really was a time where, you know, we did not have that incredible resource, and people were dying. And it was just really a landmark moment to have the introduction of these effective oral regimens. And it gave us all such hope. And the introduction of those regimens was a product of science, you know, to be sure, but it was not just a product of science, but it was also a product of advocacy. We would not have these regimens without people being in the streets and pushing for treatment, for an appropriate response to the AIDS crisis. And so I think that we, you know, owe as much to advocacy as we do to science for having these regimens. And we're also grateful about how antiretroviral therapy is not only effective treatment, it's also effective prevention. And we know this now from you know, trials like the HPTN 052 trial, now a decade old, which boy, time goes by. You know, which told us that people who are taking antiretroviral therapy and have viral suppression cannot transmit the virus. And that's been so effectively and powerfully elaborated in the U equals U, undetectable equals untransmittable approach articulated by the Prevention Access Campaign. And so that knowledge that you know, treatment is prevention, that U equals U is also a very powerful medicine, you know, not only for HIV and for HIV prevention, but also for stigma and for shame. So over time, we have been grateful because our science has advanced and improved our HIV regimens. And in the earliest days, when we did have available therapies, they were often very toxic, very complicated to take. People were on regimens that sometimes required, you know, 20 or more pills daily. They may have been on regimens that require dosing 4 or more times each day. We had people who wanted to benefit from them so much that they would wake up in the middle of the night to take their pills on time. And that was obviously extremely challenging. So over time, we've been able to simplify the regimens, make them better tolerated, more simplified, and also more potent. And so it is a remarkable thing that, today, so many years later, the majority of people who are newly diagnosed with HIV in the United States begin on a 1 pill a day regimen. And that's a great advance. And simpler, better tolerated regimens are very helpful for improving adherence to care and adherence to these medicines. Now, today, we stand on the doorstep of a whole new generation of treatment and prevention in HIV, and that is long-acting HIV treatment and prevention. And here we have a set of regimens that are in development or now advancing into use, which move product use from daily to time periods that are measured in weeks or in months. And the first ones out of the gate in terms of the clinical trials and the FDA approvals have been long-acting injectable antiretrovirals, both for treatment and for prevention. But there's really quite a large set of products that are currently undergoing clinical trials or clinical development. And that includes things like broadly neutralizing antibodies, the intravaginal rings, extended release drug implants, microneedle patches. There's a monthly oral regimen that is being advanced with some complications. And we might even include HIV vaccines in here because there's a really strong component of NIH that continues to support the effort to find an effective HIV vaccine. So all these things would be real innovations, for moving product use from daily to something that's much more episodic. And as a result, there's been a lot of enthusiasm, a lot of excitement about that. Last year, 2021, was bookended by 2 of these approvals by the United States FDA. And the first was the approval for the first extended release and long-acting injectable drug regimen for treating HIV. And this was issued in January of last year, so really just a year ago exactly. And that is a regimen of rilpivirine and cabotegravir, and it's an intramuscular injection. They do that to the right and left buttock. And although it was originally approved for monthly dosing, this is a news item, something I only learned this morning, and that is that yesterday, the FDA approved this regimen to move to a bi-monthly injection. So not once a month, but every 2 months. And that's on the basis of a trial, Atlas 2M, which showed that the bi-monthly regimen was as effective as the monthly regimen. Basically, in the trials to date, FLAIR, Atlas, and other work, what we see is that for people who are durably suppressed and who begin these antiretroviral long-acting regimens, we see that the long-acting is just as good as oral ART. So these are equivalency trials. And people do report injection pain. There is soreness that results from these, but people have been very happy. The trial participants reported great satisfaction with the regimens, partially because in qualitative research, they talk about how it relieves them of the burden of daily adherence. Not only the need to take a daily oral pill, but also the way that an oral pill can remind one of one's HIV status and issues of stigma and shame, internalized stigma and shame, as well as external concerns in terms of stigma management and how people have their pills, in a way that people might be able to see them or learn about their HIV status. So they appreciated the convenience and the privacy that the injectable regimen has afforded. Now, last year, we also closed the year with another approval, and that was the approval of the first long-acting regimen for HIV prevention, PrEP. And that is a regimen which is injectable cabotegravir. It's delivered every 2 months, and that follows an induction regimen where people take a month of oral medicine just to make sure that it's safe and well tolerated before they began the injection regimen. That was very exciting news to have at the end of, it's only a month ago, the approval came through for long-acting injectable PrEP. And that was really based off of two very strong trials, HPTN-083, which was conducted with cisgender men and transgender women. That found that both oral PrEP as well as the injectable PrEP were highly effective, but long-acting PrEP did prove statistically superior to oral PrEP in terms of preventing HIV infection. So both highly effective, but one more superior to the other. And then the HPTN-084 trial, which was conducted with cisgender women in sub-Saharan Africa, this trial, as well as HPTN-083, were actually stopped early on the basis of their efficacy signal. And HPTN-084 found that long-acting injectable PrEP was not only safe, but it was also superior to oral PrEP for women in this context. And there's still work ongoing on that trial, but they generally, it is thought that the superiority results from the consistency of the injections compared to the challenges that participants had adhering to an oral regimen. So we have these two approvals in the United States, and that brings the implementation and use of long-acting regimens to our doorstep. There's a lot of exciting opportunities, but also challenges, that could come forward from the use of these regimens. They have the expanding choice that we have in these kinds of treatment and prevention opportunities. It is going to be very helpful to have greater choice in people's options, both for treatment and for prevention. If people can select a regimen, whether it's oral or injectable and long-acting, that meets their interests and feels like it's a good fit for them, the hope would be that that's a regimen that they can then persist on and will have better use of over time. So improving choice is a very good thing. And we've seen how at least clinical trial participants to date have been very interested in these regimens. And given the efficacy signal on these HPTN trials, I think there's also some hope that there's even a potential to use these regimens in a way that could strengthen our treatment and prevention outcomes. But there are challenges, and central to that are concerns about cost and coverage. There is a very, very early work now that's coming out about the use of long-acting injectable treatment. And it does look like cost and coverage is a huge issue and an impediment to the use. In one clinical center where people were assessed for possible uptake of the long-acting ART, the only people who were successful at initiating it were people who had private insurance. And so dealing with cost and coverage is going to be a critical way of facilitating their use over time. And that's something that we'll have to work on. Equitable access and also global access. HPTN-084 was done with women in sub-Saharan Africa. How soon will these regimens be available, not only here, but around the world? And then within our country, anytime a new product is introduced, there's always barriers to equitable access. We've seen that many times, so these are concerns. And then there's other issues here about facilitating regimen choice, and also how we might manage the clinical implications of this very long duration drug. We think about, in HIV PrEP, how we have seen these concerns about equitable use. Oral PrEP, when it was introduced, it took a long time. It's taken time to gain wider and wider use. But all along, there's been deep disparities along many axes, and one of them has been around race. And in this slide, what you see is that, although PrEP awareness is very high among men who have sex with men, there is a gradient in terms of PrEP use. And that very interestingly corresponds to how often providers have a PrEP discussion with these men who may be white, Hispanic, or Black. And so it points to the role of the healthcare system in being able to, effectively bring these regimens into use and to work with people to allow access for them. And we think that that's going to come into the case with long-acting as well. So kind of foreseeing that there could be challenges in the use of these regimens, I was very fortunate to be a part of a group here at NIH. It's the NIAID NIMH Behavioral and Social Sciences project team. Here's a picture of our group. It's a variety of science and program officers, medical officers from NIAID, as well as from NIMH. And all of us trying to do work to try to advance attention to the integration of behavioral and biomedical research. And so we did have this meeting now a few years ago about thinking about how we can begin to prepare the way for the use and delivery of long-acting regimens. And that was a really exciting two-day meeting that we had here back in the day where you could meet in person. And I think that we had Bob and Teo and Claude there, among others, and about 100 people there, really from all sorts of disciplinary backgrounds to help us think about that. We did a little data collection with our meeting. And so we have this word cloud. When people started the meeting, we did ask folks who are participating in it to write down 2 words that come to mind when you think about long-acting treatment and prevention. And here you see mostly hopeful words, at the start of that meeting. Ease, adherence, choice. There's a need, an opportunity, safety, effective. So a lot of hope about these regimens and what they could do. After 2 days of talking about how we can bring them into use and to advance their implementation, we did the same activity, and here's the result. So you see some words that are recognize just the challenges that are involved in fielding a regimen that is new, complex, implementation, equity. But the hope remains there, hope, promising. So it was interesting to see the perspectives change through the course of discussion. We were able to distill the directions from that meeting into a publication which came out last year in AIDS, and that's highlighted here. And there's really, from the discussions there in the groups that were held, we were able to distill them into kind of 3 critical directions for our future work around the use of long-acting regimens in HIV treatment and prevention. And they're shown here, but let me go into those with some just briefly in depth. So the first direction that came out of that meeting was that we need to further think about the regimens that are in the pipeline, that we have to advance the development of novel long-acting regimens that are desirable to end users. If they're desirable to end users, and that includes not only people in the community, but also medical providers, then that's something that can help them to have traction, to make them stick and to have them be more useful and effective. And so the way we achieve that is through behavioral and social science research to understand end user needs and desires and context. And so there's a whole variety of examples of how people can do that through qualitative research and discrete choice surveys with intended end users. Some of the work that's been done to integrate some of this into the existing clinical trials, placebo trials, and work on how we engage communities. I think about the years of incredible and pioneering work that's been done by so many investigators at the HIV Center to integrate these kinds of concerns, user perspectives, user interests, into the development of products like vaginal and rectal microbicides as a really excellent example of doing this kind of thing. So one priority is using behavioral and social science to inform the development of new long-acting regimens. A second priority coming out of our meeting is to support the safe and effective use of proven regimens. And one way that we can do that is by trying to use behavioral and social science research to develop tools and approaches to support regimen choice, use, and care retention. And there's a whole range of work that can be done here, kind of at this user level, how we support use at the user level of long-acting regimens. One of them would be to create decision tools that offer patient-centered and shared decision-making around whether to initiate one of these long-acting regimens. And I think that there's actually some interesting work that's going on by Morgan Philbin at Columbia Mailman on this very front with women. There's also advancing retention interventions. Since these long-acting regimens are going to be delivered episodically, let's say every 2 months now with the currently approved regimens, then that puts an increasing onus on our ability to be able to engage with people over time, to have them retained in care. And so our attention might not focus on daily oral medication adherence, but it's going to increasingly focus on retention and care, and how we follow people over time. And then there's even more fundamental work to do around intersectional stigma and other social determinants as a fundamental barrier to engagement in HIV prevention and treatment. That backdrop, can impede people's ability to engage in care. And its operation is so complex. I think Miguel spoke it was a terrific presentation from Miguel about loneliness and social isolation. And I think that that's, one of those, mechanisms, between, kind of the experience of stigma and discrimination and people's inability to access care and to benefit from treatment and prevention. So there's a lot of important work to do here in the behavioral and the social space to ready access and use of these regimens. Then the last one would be to advance new models of healthcare delivery. So here we're thinking about the provider level, the healthcare clinic level, and beyond. We want to really maximize the reach and impact of long-acting regimens. And to do that, we have an opportunity to not only do the same old, but to innovate, to think about new approaches to healthcare delivery, and ones that can importantly maximize equitable and efficient access to these kinds of regimens, long-acting and extended delivery regimens. That means we have to study provider factors. We have to look at organizational capacities, and we'll need to develop trainings for healthcare organizations and healthcare providers. There's some very interesting work underway in New York by Dennis Nash and Mary Irvine, who are doing this kind of, they're assessing the interest and the capacities and the best delivery approaches for long-acting regimens in a variety of HRSA-funded care centers. We can think about how we can advance new delivery models that use these regimens. There's interest in pharmacy-based care. That's something that was called out in the new national HIV/AIDS strategy, as well as other models of community-based care and even telemedicine with home delivery of regimens. And of course, in all of these things, we have to attend to cost and cost effectiveness and coverage, and even donor programs. How can we facilitate access to these regimens, not just here, but really throughout the world? So a variety of important directions, and what I can say is that we stand ready and interested to advance further research in this area. So if you do have those interested, I'm very glad to speak with you. Also, we are working on what we will hope to soon have an announcement about a possible opportunity for a special issue. And so if you are doing work in this area, and you might be thinking about advancing a manuscript, keep that in mind, that we may have a special issue opportunity for you to apply to in the near future. Before I conclude today, let me just say a couple of last things. That is some of our ongoing research initiatives. Arguably, the longest acting regimen that there could be would be a very effective HIV vaccine. And HIV vaccine research has had a long history. It's had advances and setbacks, but NIH remains committed to developing an HIV vaccine. And the thing that we see, of course, in the recent COVID epidemic is how critical it is to have a highly effective vaccine to deal with the pandemic, but it's necessary but not sufficient. We also need to have accompanying communication strategies, communications from trusted providers and sources in order to expedite and facilitate their use. So this is a very forward-looking RFA, which is currently open, and it seeks applications, R01 and R21 applications by May. And I've had the pleasure of working with a new staff member, Colleen Lawhorn, who's leading a program for us in health communications research. And so this is an invitation to do health communications research that might be related to current HIV vaccine testing or future use. And there's a variety of different opportunities here to understand the contemporary vaccine communication landscape, particularly among those individuals who may benefit from a future HIV vaccine, and even an opportunity to leverage analogs like the use of the COVID vaccine or HPV vaccine or hepatitis B vaccines. So happy to speak with anybody who might be interested in that kind of work. I'll also point to, there's a current supplement announcement to the centers program, the NIMH centers like the HIV Center, as well as our centers for AIDS research, CFARS. And there's a few different foci in there that speak to behavioral and social science. Each center has its own application process, so I would look to your leadership for guidance on how to approach these supplement announcements. But these invite things like new behavioral economic research to advance implementation strategies in HIV, participatory data science, and there's also work on equity, again, tackling social and structural determinants of health. And I'll conclude here with by noting that I'm really struck by the increasing focus of attention to social and structural determinants of health at NIH. There's just a tremendous amount of energy here around the effects of systemic racism, as well as other social and structural determinants of health and disparities. It's something that I think is really growing. And so this is a council concept that was approved at NIMH just on Tuesday of this week. It's brand new. Frequently our concepts presage a future RFA. And this is going to encourage implementation science, which will help to address social determinants of health to support the end of the HIV epidemic here in the United States. The concept invites collaborative implementation research to develop and test interventions that target social and structural determinants of health, while simultaneously testing strategies to facilitate their uptake and adaptation. I'll let these slides, we can share these slides afterwards if people would like to see more of this, but there's an invitation here to consider the use of hybrid implementation effectiveness designs to test new interventions that will address social determinants of health alongside their efforts to speed the uptake and use of HIV treatment and prevention. And so an interesting thing to keep your eye on. So in conclusion, we have submitted a great mountain in developing our current armamentarium of HIV treatment and prevention options. It's wonderful to have improved regimens and regimen choice, and to be atop this mountain, the view is nice, and we should celebrate that. It's a great achievement. At the same time, that mountain, is really just the tip of an iceberg, in fact. And it means that, doing this work around regimens, developing new regimens, improved regimens is really just the beginning. And if we want to really create impact with our work, then we have to think about these much deeper concerns and foundations on which the regimen's success relies. And that includes better behavioral monitoring and behavioral support, working within care systems to improve the quality of care and equitable service provision. And then at the broadest level, working at the community level to address social and structural determinants of health. And if we can do these things and even test combination of these kinds of interventions, that's really what's going to create impact. So the new regimens is a start, but they won't be successful if we don't do that in an integrated and combination way with all these strategies together. So I'll conclude there. And would welcome your questions and your comments. And thank you for the opportunity to speak with you today.
Thanks so much, Michael. A reminder to everyone, if you have a question, you could use the raise hand feature and I'll unmute you, or you could type your question in the chat or Q&A feature. We have a question from our new fellow, Paul. He asks, in addition to being potentially less burdensome and easier to adhere to, do you foresee these long-acting therapies heading to less and less frequent engagement with healthcare? And if so, how will this affect guidelines for screening or treatment for other conditions of HIV and PrEP care, for example, STIs, cardiovascular disease, mental health, etc.?
Well, thank you for the question, and welcome to the fellowship program. Congratulations to you. Well, it's a very interesting question because you know, one of the challenges with these regimens is about how people interact with the healthcare system and kind of, you know, their dialogue, their interplay. You know, at present, you know, the injectable antiretroviral regimens, like for treatment, you know, if they're administered on a bi-monthly basis, then that in fact actually creates more appointments, more interaction with the healthcare system, potentially. And the reason is that, you know, under, you know, current, you know, treatment guidelines and practice, you know, many people who are, you know, virally suppressed may have a regular appointment with their healthcare provider, you know, as little as twice a year, you know, or you know, people might be coming in maybe quarterly at the most. And so it actually is, it will require more frequent contact for people to come back to a clinic and to access the injection. And at present, you know, it would be administered in that fashion. People would have to come in to do that. And so there is an interesting, again, opportunity and challenge, you know, that might invite more points of contact with people, a better chance to keep in touch, to have a heartbeat of communication, to have access to important other screenings for mental health, substance use, and other critical components of care. But the system is not built for that either. You know, the system is built for, you know, seeing people at a certain frequency. And so there's a real question in some of the very early work on the long-acting regimens. One of the challenges has been not only coverage, healthcare coverage, but also kind of a human staffing and resource challenge. Because I think the clinics are finding that to schedule people so that they can return at the proper intervals and to follow up with them to make sure that they come in. You know, there are clinics that are doing that very well, and they're doing that with success, but it takes effort. It takes an additional, you know, additional time, attention, and work to make sure that people are coming in regularly and to follow up with them if they don't make it. And so it actually invites a human resources challenge for some of the clinics as well. And that's another part of the puzzle that we'll have to work out, you know, to allow for the success of these regimens. So yeah, that'll be an interesting thing to keep a tab on as we go forward, and that might also relate to whether we're able to develop and affect, you know, new models of healthcare, which include, you know, community-based delivery of these regimens, you know, doing it through pharmacies. You know, it might be that there's an opportunity to kind of diversify, you know, where people, you know, receive these kinds of regimens. And you know, that's something that, you know, we'll have to continue to see if that happens going forward. So I thank you for your question. I appreciate that.
Thanks, Michael. We have a question from Claude Mellons. Let me unmute you, Claude. Go ahead.
Hi, Mike. How are you? Nice to see you. And this was really amazing for us at this particular critical juncture, you know, in our center. So I really appreciate it. I was going to ask you about mental health, but you actually just made me think of, you know, a few other things. But I think importantly, I guess what got me thinking about this is, you know, I had a doctor's appointment about a new medication and got to spend like a half an hour talking about the pros and cons of that medication and why I may or may not want to be interested in it. And I've been watching healthcare systems during COVID, and nobody has that time to actually spend with patients. It's not nobody has that time. In busy public health clinics and in many of the clinics where HIV prevention and treatment is offered. You know, everybody has very full caseloads, and the time to address some of those issues that you are raising, you know, stigma, but just also concerns, right, about the impact on health, et cetera. It feels like there are such huge systemic issues that are barriers to our ability to do some of what you're suggesting in here that we need. So I guess where's the interface, or what, you know, of how we change? You alluded to this, healthcare delivery, but how do we think about those systemic changes in line with our behavioral and social science and the kind of care we provide in many of our clinics, particularly to populations of color, who, you know, it's a lot of questions, I guess, wrapped up in that, but it seems a huge barrier and a huge iceberg.
Yes, it is there. Well, thank you, Claude. Thank you for your question. And you know, the systemic and the structural challenges are extremely, they are very real, and I think it will take some time for us to be able to, you know, work that out. You know, and it will indeed challenge both the delivery and the use of these kinds of regimens. You know, so, you know, I think there was a time where you know, people thought that, you know, there's always kind of this idea that, you know, we have the next, you know, silver bullet, the magic bullet, you know, that's going to make all the difference, and then it arrives, and then we realize that, you know, indeed it's much more complicated than we thought, and that there are these, you know, very deep structural barriers. The COVID, you know, the last year, you know, by all, you know, kind of anecdotal reporting that I see, as well as just one or two very early reports, you know, the start for long-acting injectable PrEP has been slow at best. And, you know, this is occurring at a time where we are challenged by COVID, where, you know, clinics have been closed. People are working on a telemedicine basis. There's, you know, challenges, you know, much broader challenges to people's engagement in care, you know, that relate to, you know, their income, their employment, their access to social support, their mental health and substance use. So, you know, these are arriving at the most challenging possible time.
Yeah.
You know, would the picture look a little different if we weren't dealing with all of that? It's hard to say. But honestly, you know, from what we're hearing, you know, the human resource issues, the coverage issues, are, you know, those impediments are real, and those would be impediments even if we weren't dealing with COVID. And that's not even getting to having the time to, you know, work with a client, you know, to really think in a thoughtful way, you know, what would be the approach that is the best match for you?
Yeah.
You know, and so I think, you know, there are some potential innovations there, you know, that could occur, you know, around, you know, the use of, you know, digital approaches, you know, to give people, you know, information to help them start to think about, you know, clarify their values, their interests, and maybe to bring that into a clinical encounter so that the patient and the provider are kind of ready to have that conversation. But we've seen some examples of that kind of work in the contraception field, you know, where there is diversity of product choice, and there people are working on have tools to help facilitate that choice. So I don't. This is a long way of saying that, you know, the challenges are deep and real, but there's still, you know, I think with research and with work, you know, there can be a way forward, you know, to help make a difference and try to get the best possible benefit out of these.
So I love your optimism and hope. I think that's always been key.
Well, you know, yes, we have to have that. Thank you, Claude.
Thank you.
We have a question from Fran Kornos. Fran, go ahead.
Unmute. Hi, I'm a psychiatrist who's worked at the interface of HIV and mental health for a very long time, but not primarily as a researcher. But I just wanted to say that we have a lot of experience with long-acting injectables in psychiatry. And I think some of the things we've learned could really be useful lessons. In other words, you don't have to reinvent the wheel, because our population is very disadvantaged. When you have severe mental illness, you're almost always poverty-stricken. I ran a program for people with severe mental illness in northern Manhattan. It was almost exclusively immigrants from the Dominican Republic. And we have gone through all of the logistical issues of how you think about orals versus injectables, how you get people to accept injectable medication. What kind of a nursing staff do you need at your site in order to do the injectable medication? What do you do when someone shows up at the wrong time for their medication? What do you do when you don't hear from them in the 2 months? Whatever. So I just want to say, there is a group of people, I happen to be one of them, but we've really had a lot of experience with the cost issues, every logistical issue you can imagine in long-acting injectables. So you might want to work with, some of us who've been doing this for a really long time.
Well, thank you very much, for that comment, and for, I appreciate that perspective, and let us let us align that with this hopefulness, that for the many challenges that there are, that we do have ways forward, and some of those ways forward mean relying on the expertise that we have at hand, and that is exactly right. We do have expertise that's available to us. And up there at the HIV Center, the New York State Psychiatric Institute, this is like a perfect example of it. But in the use of long-acting antipsychotics, and those kinds of models, give us a great, if there's an opportunity to leverage, those kinds of models, to then, and bring those lessons and those approaches into, HIV care and program delivery. That is an excellent place to start, and particularly because not only the alignment around the regimens, but because it is working with those marginalized populations. So oh, go ahead.
I just want to add that I'm also the co-principal investigator of the Northeast Caribbean AATC, and we're already starting to work with people trying to use the long-acting injectable PrEP medications. And the same issues are coming up, so I know it's the same set of issues. How do you have enough? One person who's doing a lot of long-acting PrEP really talked about the importance of the nursing staff and how critical that is. So I'm not trying to say that, I wasn't trying to say anything about being optimistic. I was just trying to say something that there's a set of issues that are going to come up with any use of long injectable medication, including whether the person can learn to inject at home. I mean, there's a whole set of things, but these challenges will be similar. The same economic challenges. The injectables are more expensive than the oral. I mean, the same need to work with Medicare and Medicaid about what they're willing to cover. All of those issues have been, there for a long time.
Well, yeah, those opportunities and the challenges. I mean, I think the provider, having a strong care organization, provider factors, those are critical to the use of long-acting injectables, in the context of psychiatry, and so we see, there both the opportunity, but also what have been some of the challenges that have limited their broader use. And so, so I do think that I completely agree. We had some individuals in our, formative meeting, that came to us from psychiatry, from areas of work, in substance use and other areas, and they, I think that this is one of the directions, that they highlighted, was that, we can build on those places that have done that well in psychiatry, while also being mindful of what where there have been challenges there too.
Yeah, I guess the main reason I'm bringing this up is that sometimes in the HIV field, especially in the behavioral health area, we start out like as if nothing is known because it's not specifically known in HIV. And I think that's inefficient. A lot is known about the use of injectable medications, so, so my argument has always been, and that's been since the beginning of being in this field, that sometimes what's also missing is people on the ground having a voice. Like when researchers only talk to one another and they're not talking to the people on the ground who are actually trying to implement, like the people trying to implement long-acting PrEP, it's easy to get into so much of a research mindset that the practical issues don't receive the attention that they could and should to move things forward.
Well, understood, appreciated, and agreed. And so thank you for offering that example. And I agree that these are directions on which we can build. I appreciate that.
Thanks, Fran. We have one question from Omar Martinez that may be for both you, Michael, and Miguel. Omar says, thank you so much for these great presentations. We have learned, I hope so, the importance of language in public health and the need to evolve and be mindful as we continue to embark on developing intervention and approaches to address the growing pandemics and epidemics impacting systemically and structurally excluding populations. For example, invisible HIV epidemic among Latinxes, COVID-19 among Black and Brown communities. For example, terminology such as MSM fails to capture sexual behaviors in general, reinforces the notion of, quote, risk, and implies a lack of lesbian or gay identity and an absence of community or networks. What is our responsibility to correct inappropriate language in real time and with the general public? And where would you like to see the field of public health or behavioral health area be in the next 10 years with respect to its use of language?
Well, that is a thank you, Omar, for that comment and for those questions. This is something that, I think that, there's ever greater attention to, and which, is something that, I think about the program that we're establishing here in health communications. And, there's research to do in health communications, but one critical component of that is about the language that we use, and I think about the move to, person-first language, and the adoption of destigmatizing approaches, people living with HIV, as a great example of that. And, there is, different opinions and perspectives around, what the right language is, when we're talking about, I think I relied on the, the CDC slide that has, MSM. So, that's something I want to do better on, as time goes by. And I learn, I'm a learner, every day, about what is right and good and better, what was more appropriate and what makes, offers the best respect to people. So that's a commitment that I want to do, is to better learn, to use the best language so that we can be more effective. I can be more effective in our work and we can be more effective in our work. And I do think that CDC has put out a language guide. Our friends at NIAID have a language guide. I feel the federal government is just getting better. We have a long way to go, but that's that effort is underway.
Thanks, Michael. Miguel, did you want to comment?
I agree with Mike's perspective on the importance of language and the importance of, and I think it's also important to distinguish between epidemiological terms versus engagement in care terms. I think those are, to me, those are very different elements. And I remember, in a way, the history of the term MSM and why it was done in the first place. It was supposed to be destigmatizing, but again, it's how do we go from the uses of epidemiological terms and categories into then engagement in care and health promotion and full engagement. So I think these are it's a good constant ongoing challenge if we want to engage people in care. So thank you.
Well, we are approaching the end of our time together. Thank you both, Michael and Miguel. Bob, I'll turn it back to you.
Thank you, Stephen, and thank you, Miguel and Mike. You know, we're not surprised. You know, you both are. We're proud of you. We're glad that you're colleagues of ours, and as Mike referred to, these sort of interconnections, we're just so pleased that that continues to go on. So thanks so much for everything that you brought to the table today. And it's just so great seeing you both. And, you know, and thanks for welcoming our new fellows. So let me just remind everyone of, I'll just remind you again of our next upcoming grand rounds on February 17th with Monica Gandhi, talking about HIV adherence metrics. A lot of this I think will be very relevant to what we just heard from Mike Stirratt. And then also mark your calendars for March 31st for our Zena Stain commemorative rounds. So thank you, everyone. Thank you for being here. And thank you to our guests especially. And have a good week. Take care.
Thank you.